Okay, welcome back. Last session. I need some paracetamol after this. Has anybody done any pharmacogenetics of paracetamol? Acetaminophen, actually. Okay, so we're going to have the rapporteurs telling us what they discussed within their groups. We've got half an hour or so to go through this, and then we can close after that. So, which group wants to go first? Duffrick, does your group want to go first?
Yes, I guess so.
Okay, so are you going to be the rapporteur? Do you want to come up at the front?
Yeah.
And have your 5 minutes in fame?
I'll have my 5 minutes. I'll be next to him.
No, over here. You have to stand here. You can't get away with sitting there.
Okay. Okay, so...
and you need to use the microphone.
Oh, yeah, me. Okay, so Professor Hughes chaired our session, and he took quite a structured approach, and so I speak very loudly because I'm Oriental, and we tend to shout. So I never have people saying they can't.
Please use the microphone because we're recording.
They can't hear me even from the back of a room when in NHS meetings when the microphone is not working. Okay, so we first consider the opportunities, and broadly, I think we felt that the main opportunity there was there was an opportunity here to avoid drug reactions, a real clinical opportunity there, with reduction in morbidity and mortality to our NHS patients. And also, related to that, some financial savings, obviously, potentially associated with the improved care of our patients. It was felt that there was also a conversation around how we could refine improving and reducing drug reactions. And it was suggested maybe through patient empowerment, through modern technology such as having apps associated on patients' mobile phones. Then there was also the opportunity, and there was quite a lot of discussion, I think, around the opportunities for research. And I think this is against the background the group felt of the advantages we have within our NHS. Firstly, it was highlighted that we have our payment system, our reimbursement system, NHS reimbursement system facilitates that, and it was contrasted and juxtaposed perhaps against the North American US system, which perhaps had more challenges when it came to research in this area. There was also the opportunity for research because currently, as we know, there are new structures, organizational structures which have been developed within the NHS with specialized services. There are also the physical structures which, with regards to within the NHS around data collection, data which felt would provide opportunities for research, and also the at the same time the Genomics project provided us with opportunities for research, and specifically research around analytics and machine learning. And also it was specifically expressed that in addition to those patients, there were also included in the Genomics project a significant number of healthy adults and their genetics, which we will have available to us, which could be used for research. And then I think Professor Hughes specifically asked about perhaps those areas which are most likely to deliver early successes, low-bearing fruit, I guess. And it was suggested that rather than, to achieve this, rather than focusing on all 80 drug allele pairs, to focus on perhaps a limited number. But a dozen or what? I think there was a discussion around, which do we select? Those with most severe side effects, or those which are, regulatory agencies most highly recommend. I think there was a discussion, and it was still, I think, a matter of discussion. The challenges there were some challenges, and firstly, I think one of the challenges that was raised was that it was felt that there was need to increase awareness of genomics amongst healthcare professionals specifically. There was then a conversation around what was the education that was required and to whom. A lot of the discussion was focused around GPs and the education for GPs. And then the discussion around GPs, then what was the level of education that was required? And I think there's a discussion, should one take a pragmatic approach where in fact they don't need to really understand the details of the mechanisms, etc. All they need to know is that there's a risk associated. Or do they, in fact, need to have a detailed knowledge to be able to explain to patients? And I think there was a feeling that, in fact, not one size fits all. Patients are different, GPs are different. And so, I think that's still something which the group felt required some discussion. It was highlighted that in the genomics project at the moment, there's uncertainty around some of the data and how to interpret the data, and that's a challenge. There was also brought up the barriers of implementing some of these opportunities was the need for resource. And I think there was the need for resource with regards to data collection, and there was also need for resource with regards to providing incentives for testing, because it all takes time and resource, and someone has to do it.
So from the Blue Group, the first thing that we discussed, has already been touched upon, is possible opportunity presents itself due to the current timing, and there's a current alignment with national policies. So there's the reconfiguration of the genomic laboratories, there's the work going on to decide what variants are going to go into the test directory to help standardise this work. There's the data examplers, and as we've already heard, the integrated care facilitated through the STPs. All means that there's a lot of change happening, which is a challenge, but there's also perhaps an appetite to really jump on the back of this change and use it as a vehicle to implement pharmacogenomics, whilst people are having to accept a lot of changes at the moment. We also covered extensively education. This has to be from the outset, it has to be ongoing, it has to be multidimensional, it has to be provided in a lot of different modalities. And thinking about education for the prescribers, one key area is going to be helping to educate people about how to consent for these genetic panels, the logistics of when to do it, and also how to provide some education about the consultation process, because otherwise there'll be concerns on the front line that or perceived fears. I don't know how to consent for this, I might get it wrong, or it's going to take too much time. And as we've already heard, there needs to be education happening from both undergraduate and postgraduate levels. We also thought about, as well as really try and harness the pull from patients and a few innovative ways to engage the patient population. We have to get this right. If we get it wrong, and the example of GM crops was put up, if we get this wrong, people will get scared, fearful, and that'll set us back a decade. So we have to really work closely and sensitively with our patient representatives, and also go out to the broader population. So some innovative ways. We'd wondered, should we invite the script writers of Casualty or Holby City here, get it on Coronation Street, a little story about pharmacogenetics, as well as Horizon or a Channel 4 documentary. We've already heard, but clearly a major challenge in any implementation is the logistics. Everyone's busy, so it has to fit into the current workflow paradigm. And therefore, as well as I suppose the potential benefit of picking some pioneer drugs to roll this out with, we also have to think about the practicalities. And we've already heard, for example, clopidogrel used in preoperative surgical assessments. That might be that's codeine, or clopidogrel could be another example, because if we're going to have to try and interrupt the current workflow and bring patients back, that will lead to a lot of resistance. Other examples potentially where we could start could be fluoropyrimidines and DPYD, and maybe point of care testing as well, specifically for warfarin in the anticoagulation clinics, as well as highlighting to, if patients is going to be identified as an inpatient and they're put on heparin, try and educate the hospital doctors to get the genomic test off, so when they go to their anticoagulation clinic the following week, the test is ready and waiting for use on when the warfarin. If the patient has decided to go on warfarin rather than the DOAC, that decision's made in that first anticoagulation clinic appointment. We notice there's a dearth of people with an informatics background here, and clearly we need to work closely with them. There's lots of challenges. If only 30% of hospitals currently have electronic prescribing, then we may need interim measures to help make clinical decision support available through web-based portals and so on. I probably have missed things.
About genetic counsellors or genomic counsellors, ways that we need to think more about. The incorporation of genomic counsellors into the process, and also making best use of physician associates in general practice and elsewhere, and the pharmacists as well.
So really trying to work with all the allied health professions. And I think a point was made that right across the world, there's insufficient genetic counsellors, so actually we could again lead the world with this.
Thanks very much. Our group had a very lively discussion. We actually misread the question, so we did challenges and opportunities rather than opportunities and challenges. We started with a story from one of our group about her father, who'd been in an NHS hospital for a simple knee replacement, I think it was, who had a codeine intolerance, who hadn't told the doctors, said he was fine, came into hospital, had an anaesthetic reaction, a series of reactions to his analgesia, which he kept being taken off by one medical team, put back on by the next medical team, leading to lots of complications and a very prolonged hospital stay. Whilst to me this was clearly a case for pharmacogenomic testing, to her and her father, this was a case of terrible communication between the medical professionals. And this led to a big discussion on the House of Babel that is the current NHS and the complete lack of join up of any information system. For example, our ward is still on paper folders, and even allergies are getting buried. So the first thing we felt that an opportunity, or we went for solutions as well as problems, was that we really need to, well, I think this is perhaps an impossible suggestion, but we need to sort out NHS IT. Because I know that's a bit grandiose, but some suggestions that were offered were, for example, involving big data companies. For example, Google and Microsoft, perhaps trying to break down people's natural resistance to some commercialisation of the NHS. There was a lot of enthusiasm for patient-held records, cards or smartphones. We love the UPGX card and the little thing that you could scan and get into the information, and perhaps a centrally held record. We discussed the problems of GPs and hospitals not being joined up, but pharmacists, especially community pharmacy, really not being joined up. So one-way traffic from the GP to the pharmacy, and if patients are reporting their adverse reactions to pharmacy, they're never coming back to primary care. And we talked about pharmacy as a business, and there being opportunities in pharmacies out with hospitals to perhaps be offering apps and lists of medicines and your pharmacogenomic records perhaps as a service. In this great house of Babel, we also have complete chaos. For example, most teams in my hospital have had double the number of patients over this winter period. Everything's so busy, it has to be done at a run, and so there is no time. And so it's going to be really, really important that the people at the sharp end who are implementing pharmacogenomics have the information very short and simple, just told what to do and do it. And so there's going to need to be a different level of education for depending on your role, and there needs to be some sort of referral or specialist service that can help and support the average clinician in delivering this. Clinical pharmacists clearly have a very important role. We felt that there should be a clinical pharmacist on every ward integrated in the team and also in every GP practice, and we know NHS England is going some way to that. As a clinical pharmacologist, please accept my vested interest, but we feel that there's a really important role for clinical pharmacologists here, working with clinical pharmacists and geneticists, perhaps as a multidisciplinary team or a referral. We heard some great examples from the States of pharmacogenomics clinics for the really complicated patients where people don't know what to do. And enthusiasm from my GP colleagues for such a service to send their difficult polypharmacy, polygenetics actionable patients too. So we felt some specialist expertise to support the general public in the general NHS in delivering. We also felt that if you want somebody to do something for a prescription, it needs to be in the indications and dose section of the BNF. So it's people have it on their app, they only read the first bit, they don't usually get down as far as renal function. So for where there is an actionable, it needs to say, if you have a poor metabolizer, give this dose. Not make it complicated about 1 star, all of that. And we really need to find some clinical pharmacologists or pharmacists in the BNF who could work with us on this in getting information into the BNF. I'm looking at Munir because he knows everybody. It needs to be clear, straightforward, dichotomous decision-making that's as clear as possible so people can do it like that because they only have about a minute to do it. We felt that talking to patients is very important and involving patients, but we felt there mustn't be counselling. We thought about the HIV example where HIV has been a special test with counselling because it had a terrible prognosis. It's taken it years to become acceptable in the NHS and therefore to be used as widely as it needs to be. And we thought that, so we had another talk a little bit earlier about possibly testing in primary care and how it could be done with other screening like the vascular screen, maybe with a leaflet beforehand so people could ask questions. Maybe the clinical pharmacist you could make an appointment with your clinical pharmacist to discuss that test more if you needed to. We thought about money. Most hospitals have and primary care have a real requirement to reduce their costs. No one is going to pay from these tests unless they're centrally funded. I believe if they go on the register, they will be out of tariff. That is absolutely vital if anyone is ever going to order these tests. My hospital won't let me do them unless they're paid for. I'm going to end with a slightly pessimistic point made by our chair, which was, have we missed the boat with first generation tests? A lot of them are on drugs which perhaps have become superseded, I'm sorry about this controversial point, Munir, by more modern drugs, so warfarin and the Derax, for example. I think our group felt that that wasn't the case, and that even if the sort of first generation of pharmacogenomic tests would have some clinical applicability, but we need to almost force open the tightly sealed NHS and get pharmacogenomics in there. And this is a way to do it before we can get anywhere. We need to sort of lay the path, if you like, for the second generation big data, and we're going to have to do that with something that people can get their heads around before we start trying to get the big data in there. I hope I represented our group discussions with a few of my own particular points. Thank you.